Are you ready for another GI focus on this next episode of Digest This?
Welcome to Digest This, the show that helps you revolutionize your digestive health. Here are your hosts, Dr. Liz Cruz and Tina Nunziato.
Hello and welcome to Digest This. I'm Tina Nunziato, and with me is the beautiful Dr. Liz Cruz. Welcome to your show, Dr. Cruz.
Thank you so much, Tina.
Yes, so here we are in February 2026, kicking off the year with another GI focus.
Yay.
For those of you that don't know what a GI focus is, it's basically where we come up with a GI topic that maybe someone has asked us more about, or maybe Dr. Cruz said we got to talk about this topic. And then I ask her questions about the topic so that we can learn more about this GI thing. So today's topic is going to be on a tortuous colon.
Ooh.
Sounds
What's that? I
tortuous.
want one.
Yes. Okay, so Dr. Cruz, in typical GI focus fashion,
Yes.
I ask you, what is a tortuous colon?
I would say in the simplest definition, it's basically a twisty colon. How's that?
And that's the end of this podcast.
Thank you so much for joining us.
Yes, exactly. Yeah. So a twisty colon. Get out of my head, Cruz, and my voice. Okay. Anyway, twisty colon. So you do have patients when you're doing a colonoscopy, they have a tortuous colon.
Yes, absolutely.
And I'm going to assume that those procedures are a little bit more difficult.
So they can be a little more challenging. I mean, that's when I'm having a little bit of a difficult time because it's so twisty. Those are the ones where I will then tell the patient afterwards, so just want you to know your colon is a little tortuous. And they're like, what? And so, yes, those can be a little challenging, mainly because they're twisty.
And the husband and wife are there going, yes, they have a tortuous colon. Yes, that matches their personality.
Exactly.
No, just kidding.
Yeah, no.
So I know you have techs in the room with
Yes.
you and nurses and
Yes.
anesthesiologists and all that. So talk about when you have a tortuous colon that you're dealing with, what do you ask them to do to help you through that procedure?
It's a great question. So sometimes if I do run into a colon that's a little twisty and I start really realizing that early on when I put the camera in, sometimes the scope itself, because it's a long tube, will start to loop up a little bit. And I know that that's hard to understand, like what that means. But basically what happens when it's looping up, it's not going anywhere. Yeah, I'm pushing and the scope is just looping up on itself like a hose, like a water hose, but it's not going anywhere. And so sometimes I'll have the endoscopy tech that's working with me apply a little bit of pressure on the patient's abdomen just to kind of help prevent the camera from looping on itself, and so that we can keep it straight as I'm maneuvering through the turns.
Because the idea is we need to get the colonoscope all the way to the end of the colon.
Exactly.
So if it keeps looping on itself, you're not progressing.
You're not going anywhere. You're just kind of staying there. So a lot of times they will help me with the pressure that they use, and the tech knows exactly what they need to do. And usually, I'm guiding them and telling them. But if you have a tech that is very seasoned, which most of the techs I work with are very seasoned in what they do, and they know what they need to do. So they will help me, and then I'm able to navigate and push the camera where it's actually moving, and then just kind of navigate it gently through the turns in that colon.
And I know that some GI docs have different ways of doing procedures. Are you the type of GI doc that will get the scope all the way to the end, and then as you're pulling out, you start taking biopsies and removing polyps? Or are you doing it on the way in as well?
So the way that we were taught, okay, and this is the way we're all taught in training and fellowship, is that you go in, get to the end of the colon, which is actually the beginning of the colon, right? Because the end is the rectum where you enter. But you get to the beginning of the colon, and then as you're pulling the scope out is where you're doing your careful look at all the walls of the colon to look for polyps. However, having said that, as I'm going in, if I see a polyp,
Mhm.
usually, I mean, unless the polyp is in the rectum where, I know it's right there. As I'm going in, if I see a polyp, I take it off while I'm there.
Because sometimes you're not going to see it on the way out.
Yeah. And so I've experienced that early on in my career, that as I was going in, if I saw a polyp, I'd be like, hey, I'll get you on the way out. And then I go in and then I'm coming out. And for whatever reason, I'm having a hard time finding it because it's hard. Sometimes these polyps are hiding
Right, in a fold. Right.
And so that's why, you have to be really careful as you're coming out to be looking behind the folds. And that's also why it is standard of care that once you get to the end of the colon, which is the beginning of the colon, and you start pulling back, that it's a standard that you have to spend at least 6 minutes in the colon coming back, because there are some docs that they get in and then they pull the camera out within 2 minutes and they're done. You're going to miss polyps. You're going to miss stuff. As I'm going in, I learned early on in my career, after spending, not taking off a polyp, and then as I'm coming back, now I can't find it. And it takes me 20 minutes to find that polyp. As I'm going in, if I see a polyp, I take it off. Take it off while I'm there, and that way it's out of there.
It's awesome. Now, you wore your shirt today.
I did.
Of the digestive system. Now, this is the shirt we use when we do our digestive health talks. But
exactly.
I'm glad you wore this shirt today because we're talking about the colon.
Pull it up a little bit.
And typically, like Dr. Cruz said, this is the end of the colon where the rectum is, right? So the colonoscope is going up here and it's going around.
Yep.
And then this is the beginning of the colon over
exactly.
there, right? Okay, now, in a tortuous colon, what would this shirt look like?
There'd be a lot of turns.
A lot of
little turns, little twists. And so
how does that happen exactly? And why does it happen?
That is such a great question, Tina. So let me tell you that it's just the colon that person was given. Okay. It's not that something happened, as they're growing up.
They got punched in the stomach or something.
It's another variant of their colon. It's not a disease. It's just the way anatomically that their colon has developed, whenever they were in utero and as they were growing, as their intestine was developing. Okay. So it's like a congenital formation. I don't even want to say malformation. I don't even want to say malformation because it's not. It's just the colon that they have. It's a little more twisty.
Probably a hereditary thing, I would assume.
Maybe it's hereditary.
Yeah.
I mean, but it's not a disease. It's just the conformation or the shape of their colon.
And on that note, we're going to take a break and we're going to do our commercial.
Yes.
So we talked to everyone last year about starting this year, we're going to do commercials in the middle of our podcast for our products because they are amazing products and we want to make sure everyone knows about them. And Dr. Cruz and I picked the Delicate Detox to do this commercial. Why, Dr. Cruz?
Because there are some people that, as a result of having a tortuous colon, can develop some issues with constipation, okay? And probably because the stool has to go through more twist than typical. And so they may tend to get a little bit backed up and constipated. Detox is an amazing thing to take on a daily basis, very gentle, that is going to help to detox your body, okay, which we all can use some detoxing, especially after the holidays, but also that will help a lot of people with their bowel movements, all right, and helping them to have better bowel movements. So detox, very gentle on the system. It's just basically a very strong protease that helps to break down toxic proteins and could help not only with detoxing your body, but also could help with your bowel movements.
Yes. And the other focus of the fact that we just went on a trip and we've been focusing on detoxing
exactly
since we've been back. So we've been doubling up on our detox
yes.
since we've been back. So there you go. Commercial on the detox. And now back onto the tortuous colon. Yes. So when you tell patients they have a tortuous colon, Dr. Cruz, and they usually go, what?
Yes, they usually have big eyes.
Right, exactly.
And you got to keep in mind, they're also just waking up. Sedation is wearing off. And so they're kind of like, what do you mean I have a tortuous colon? What does that mean? And it's interesting because if I do find a tortuous colon on someone who does struggle like with constipation, to me, I will be like, oh, no wonder this poor guy or this poor girl is having issues with their bowel movements. They've got
It's not
all
a
these
normal
little
colon.
twists. Yeah, it's a different variant of a colon that probably makes it a little more challenging for the stool to get out. And so I'll tell him, I'm like, I think we have an answer for your constipation. We need to make sure you're drinking a lot of fluids. We need to make sure you're getting good fiber in your diet. We need to maybe get you on some probiotics and detox that'll help you. And then there's others where maybe they don't necessarily have issues with their bowel movements. And I just explain to them, look, this is not a disease, because they get big eyes wondering like, oh, what did I do? What do I have? I'm like, it's not a disease. It's just the shape of the colon that you were born with.
Yeah. And there's really nothing you can do about it. It's not like you can fix it.
No.
Yeah.
I mean, could you develop a major twist in your colon, like something that we call a volvulus, which is where the colon gets very twisted up, and it could cause an obstruction, which is not a true obstruction. Like you don't have a tumor or a mass sitting there. It's just that the colon is twisted on itself. Yes, that's not the typical, but it can happen. So I just explained to them, I don't go into details there in the recovery room of, you could develop an obstruction or something like that, because it's not the typical. And
it's very rare.
I think the main thing that some people may experience is maybe difficulty, with constipation and maybe not having as regular of bowel movements and maybe having to strain and struggle a little bit.
Yeah. And it's good for them to know too, that they have that so that they can inform other GI doctors in the future, because, the next GI doc that goes in, they're going to experience the same thing.
Exactly.
So just kind of giving them a heads
up. And I
up.
have had patients who have told me, maybe it's the first time I'm doing a colonoscopy on them, and they'll say, oh, my other doctor told me I had a really tortuous colon. I'm like, oh, thanks for letting me know. It's kind of nice going into it, what I'm going to encounter as I travel through your colon.
So how long does a typical colonoscopy take? And then how long does a colonoscopy take of someone who has a tortuous colon?
Oh, that's a great question. I mean, in general, I can typically get to the end, start in the rectum and get to the end or the beginning of the colon, like, within a minute, maybe 2 minutes. I mean, I'm not racing as I go in, because I want to be very gentle. If I get into any issues where I realize it's twisty and maybe the scope is looping on itself, I'll try to get through those areas. But if I find that I'm looping up, I just have the tech help me. I have no problem having the tech help me. I mean, I remember, in my training, it was almost like a sign of weakness if you had to ask the tech to help you, and as I went through my career, once I was out of training and going through my career, I was like, that's so ridiculous. We're all there as a team
that's what they're there for.
Exactly. We're there to take care of the patient together. So I have no problem asking the tech, hey, can you give me a little bit of pressure, and the tech, if it's a really good tech, they can see, and if they see that I'm struggling, they just go right around and start giving, they're like right there, ready to give me some pressure. So that might take maybe, an extra minute or two. And then as I'm coming out, I am not known for my fastness. Okay. That is not, I'm known for just taking my time and just working my way out little by little. You have to be in there 6 minutes. I've worked with nurses. They're like, do you want to know how many minutes? I'm like, no, because I have never that's never been an issue. I know I'm going to be in that colon
way longer than
6 minutes. Yeah. So I would say on average, about 15, 20 minutes for a colonoscopy, unless I'm finding a lot of polyps, then, 30 minutes. And
but once you're in and you kind of struggle getting into the tortuous colon, it's actually a little bit easier to come out.
Oh yeah, once I'm coming out, absolutely.
So
once you've
gotten it's
just going in where it's more the struggle. And then once I'm coming out, and somebody has really twisty colon, even when you're coming out, sometimes as you're coming out, you'll like zip out of an area, and then sometimes you have to go back in that area to
Mm.
make sure you got a good look at everything. So yeah,
Because
it's
the
typical.
twist kind of pushes the scope out
Exactly,
faster.
exactly.
Interesting.
But it's usually going in
Mm-hmm.
where it's the struggle. But once you get to the end, then
Mm-hmm.
as you're coming out,
Mm-hmm.
just looking at all
Do you
the
ever use
surfaces.
air in those situations,
Yeah,
or CO2, I guess,
CO2, yeah,
is
is what
what
we use.
to kind of open up the area, or not really in
Absolutely.
those
Well, as you're going,
situations?
it's a combination of putting CO2 in to
Mm-hmm.
open it up so you can see where you're going, and then kind of getting CO2 out of there.
Mm-hmm.
Because sometimes if you overinflate the colon,
Mm-hmm.
it actually makes it more challenging
Mm-hmm.
to push the camera through. So it's a combination. It's a constant. As I'm going in,
Mm-hmm.
I'm putting some CO2 in, I'm pushing, I may pull the scope back if I'm looped up. Like
It's delicate
it's like a
balance.
concert of different things that I'm doing to get the camera through, putting some CO2 out and then in other areas, getting the CO2 out. It's amazing. There'll be areas where maybe it's, with filled with air, where as I pull out the air, then the camera goes in,
Mm-hmm.
so it's like a constant,
Didn't realize
a
the
constant symphony
delicateness.
of different
Yes.
maneuvers that I'm doing to get the camera all the way to the end,
Well, thank you for
which I
learning
really
all those
don't think
things.
about it as
Yeah,
I'm doing
you're
it,
just
because
doing it.
I've been doing it for
Yeah.
over 2 decades, and it's just like a automatic thing that you're
Yeah.
doing.
Yeah.
So
It's like you don't realize how much you've learned until you're
yeah,
trying to teach somebody for the first time.
exactly.
Yeah. You're
Yeah.
like,
I
yeah, I
mean,
don't even think about that
you even
anymore.
asking me, I'm like, well,
Yeah.
it's
Yeah.
not just one thing I'm doing, it's
Yeah.
multiple little things.
Interesting.
So
All right.
yeah.
Well, thank you
Yeah,
very
thank
much, Dr.
you.
Cruz. I
Thank you.
appreciate that. So thank you all for joining us on this podcast. If you have not rated us, please rate us and go give us a 5. Please subscribe to the show so that you never miss an episode. And if you want to connect with us, you know where to go. Go to our website, drlizcruz.com. It's drlizcruz.com. There is no dot after the doctor. The dot comes after the cruise. Okay. So we will look forward to catching you on the next podcast.
Thank you for joining Dr.